All right, team, let's jump right into this high-yield explainer on substance use disorders. We're going to break down exactly what you need to know for the NCLEX, focusing on safety, pharmacology, and yeah, your professional duties.
So, to get our heads in the game, let's kick things off with a super important safety question. I want you to keep this in the back of your mind as we go through everything, because the answer is really at the core of safe nursing practice.
Okay, so to really get addiction, picture this. The brain's reward system is like a seesaw. The binge or intoxication stage, that's when a flood of dopamine slams one side of the seesaw down, creating that high. Well, the brain tries to fight back, to balance things out, by creating a ton of anxiety and stress, and that's the withdrawal stage. This whole imbalance leads to the final stage, preoccupation, where there's just this intense craving to feel normal again. It's this vicious cycle that totally hijacks the brain. Now, this is something the NCLEX loves to test you on. You've got to know the difference between these two. Physical dependence, that's all about the body's reaction. Think tremors, nausea, the physical stuff. But psychological dependence, that's the mind. It's that powerful emotional compulsion, the intense craving and obsession. You have to be able to tell them apart.
This is one of the best ways to visualize just how dangerous alcohol withdrawal is. So alcohol is a depressant, right? It's like a hand constantly pushing down on a jack-in-the-box. To compensate, the brain is pushing back up with this massive excitatory force just to stay alert. So what happens when you suddenly take the alcohol away? That spring just violently bursts out. And that is what causes the extreme hyperactivity, the seizures, and the delirium.
Okay, this timeline? You absolutely have to have this memorized. No joke. The mild symptoms, they start within hours. But the really lethal complications, we're talking seizures and delirium tremens, they can show up anywhere from 6 to 96 hours after that last drink. Knowing this timeline is how you anticipate what's coming and intervene before it becomes a full-blown crisis.
And that brings us to the most dangerous stage of all, delirium tremens, or DTs. These are your giant red flags, severe vital sign changes, a high fever, drenching sweats, and a really altered mental status. This isn't just a patient who's a little agitated. This is a true medical emergency that needs immediate ICU-level care to prevent death.
So after all that, what does it all boil down to? It's one single piece of information. Your entire plan of care, every single intervention you make is based on the time of the last drink. That one fact tells you exactly where your patient is on that withdrawal timeline, and that's why it's always your priority assessment.
Okay, switching gears now to opioids. The best way to think about this is like a lock and a key. Opioids are like these perfect little keys that fit right into the brain's receptor locks. When they turn, they block pain and cause euphoria, sure, but they also turn the key that shuts down the brainstem's control over breathing. And that's the mechanism that makes an overdose so incredibly deadly.
This right here, you need to recognize these three signs in a heartbeat. This is the classic opioid overdose triad. Pupils that are constricted down to a pinpoint, a respiratory rate that is dangerously low, we're talking less than 12, and a decreased level of consciousness. If you see these three things together, you should be screaming opioid toxicity in your head.
So you suspect an overdose. You don't hesitate, you act. First, call for help. Then, support their breathing. Then, give that first dose of naloxone. But pay close attention to step 4, because this is a classic NCLEX test point. If that first dose doesn't work in 2 to 3 minutes, you give a second dose. You do not wait around.
All right, listen up, because this is a huge NCLEX trop. I see students fall for it all the time. You give naloxone, the patient wakes up and you think, pew, crisis over. It's not. Naloxone wears off way faster than most opioids do. You have to stay with that patient, monitor them constantly because they can slip right back into respiratory arrest in the blink of an eye.
Okay, so we've talked about depressants. Now let's flip the script and talk about stimulants. I want you to picture a rocket ship. The drug floods the brain with dopamine and it just launches the user into this state of extreme hyperactivity. That's the high. But when that rocket fuel runs out, the ship just plummets back to Earth. And that's the crash, a really profound, deep depression that comes from all that dopamine being used up.
So while that rocket is blasting off, that's the intoxication phase. These are your red flags. The cardiovascular system is in total overdrive, which puts the patient at a super high risk for a heart attack or a lethal dysrhythmia. And notice the pupils. They're dilated, the total opposite of an opioid overdose. That's a key feature that helps you tell them apart.
And here's the really critical thing you have to remember. It's a huge difference from opioids, where we have naloxone. For a stimulant overdose, there is no antidote. We can't reverse it. Our treatment is purely symptomatic.
We're using benzodiazepines to try to calm the heart, control agitation, and hopefully prevent seizures. Now, when it comes to withdrawal, your priorities are going to be totally different depending on the drug. Let's break it down. For opioids, withdrawal is absolutely miserable. I mean, it's like the worst flu you can possibly imagine, but it's not usually deadly. So your priority is comfort. But for stimulants, that crash causes such a deep depression that the risk of suicide is incredibly high. Your number one priority is immediate safety and suicide precautions.
This table gives you the rundown on the main medication-assisted treatment, or MAT, options for opioid use disorder. Methadone and buprenorphine are great for managing withdrawal and cravings. But I really want you to zero in on naltrexone. It blocks the high, which is good, but here's the red flag. If a patient stops taking it and then relapses, their tolerance is gone. Taking their old dose could easily be fatal. This is a critical patient education point.
Okay, let's pivot now. We're moving away from the clinical side for a second and into something just as important and heavily tested, the impaired nurse. This isn't just about clinical knowledge. This is about your professional and legal responsibility to keep patients safe.
Listen, these are the kinds of subtle cues you are legally required to pick up on. It's usually not one big thing, right? It's a pattern. Are their patients' pain scores always high no matter what? Are they wasting way more narcotics than anyone else? These are the little red flags that could point to drug diversion.
This slide is maybe one of the most important for your career. It's all about what you do and what you absolutely never do. You never confront the nurse directly. You never cover for them, and you never, ever ignore it. Your one and only correct action, the gold standard, is to immediately report your specific, objective concerns up the chain of command to your supervisor. This protects patients, period.
All right, time to apply all this. Let's walk through a classic next-gen NCLEX scenario. You've got a post-op patient, 24 hours out from surgery. They told you on admission they didn't drink alcohol, but now they're shaky, their heart is racing at 120, and they're getting super anxious.
Okay, think back on everything we just talked about. What's your absolute first move here? What's the priority to keep this patient safe? Think about that withdrawal timeline and the fact that use is often unreported.
The answer? You have to assess for withdrawal. Why? Because patients frequently, and I mean frequently, underreport their alcohol use. Those unexplained vital sign changes are your big clue. You need to immediately grab a validated tool, like the CIOA scale, assess the severity, and get the provider on the phone. Suspecting withdrawal early is truly the key to preventing a medical catastrophe.